was that we did the Facebook Live was before the surgery, the day before on a Wednesday. The surgery was a Thursday, and now I saw you earlier in the morning, and I want to thank you again for coming forth and sharing your journey, so that we have seen the before the surgery interview, we have seen from the operating room, and now you're here, post update number 4, after the surgery. Now let me ask you this: how was your overall anesthesia experience post-op?
Post-op, I mean, I had the Exparel.
Yes.
I had the Exparel, and I have to say, I think that it really worked because I didn't have much pain at all, and I don't know if I was oxygenated from.
Every person is given oxygen because this is always the case.
I talked and talked and talked and was so active until about 9 o'clock that night. And but waking up from the anesthesia that's of course always kind of funny. It was quick, but I literally thought I was inside of Facebook. And that was my question was, am I in Facebook? No, but I woke up quickly.
Right. So
And I remember the ride back to the hotel, and then I ate like a fiend, so that was good. So, but pain, that was
Good. Now, for those patients who are listening, Exparel is a local nerve agent that's given around the chest breast area. So for up to 3 days, 72 hours, you have good block. So when you go to the dentist, they give you a shot and you're okay for 3 to 6 hours, 8 hours, and then it wears off. In this case, for 3 days, the 72 hours, you have that what is, I would say, very effective block, if you ask me.
It is. For me, it was really, I could tell, the middle of the day after, it was like, I can tell it's starting to wear off. So I did take, I took just like you explained, took half of this pain pill or half of whatever, half doses, very low, very small.
And remember, they're there for your support. And as you can see, you saw the pictures and the videos from the surgery. Yes. So you can see the area that was dissected, relatively speaking, I could take a small bowling ball and put it in the chest.
There's a video that I can't believe it. His whole hand is in the pocket. His whole hand.
So the area, so this is another very important point that you mentioned, and the area, when the implant is placed, it is much further up. Now over time, the implant just gravitates downward and outward. So the implant capsule is sitting down there, but now as I go in, I have to remove all of the capsule that's much further up, so that the entire capsular burden is removed, especially in that corner. And especially you and everyone else, all of that capsule spread has to be removed, because if there was that history of ruptured silicone, which was in your case, all of that badness needs to be removed along with the implant and the capsule, and what is that end block fashion, such that there is no inflammatory burden, capsular burden left behind, and that all whatever is removed is ultimately tested, which is it's in the face. So the up and down cut that is made does not allow for adequate and definitive access to all the way up. In my mind, I have to make a cut parallel to the ribs and then go all the way up, and that's the only way ultimately without disturbing and hurting the breast tissue. So I don't make any cuts up and down, I don't make any cuts around the nipple areola, I only make a horizontal cut. And as you saw, I removed that excess skin at the bottom that really helps with the aesthetic contouring. Now for someone 68, and given the nature of the dissection, which I would say extensive, and it was a tough surgery above the muscle, the fascia of the pectoralis major was removed along with implant and all capsular tissue. Now, you clearly did not need drains 4 days later.
I didn't need drains, and I'm so glad, because I've had 2 sets of implants put in. I've had drains before, albeit they were just for a few days.
Mm.
But I never liked them because it was always, it made me uncomfortable to think, while I'm sleeping, what if some of that goes back up? It
So
freaked me
it
out.
normally does not happen because the bulb is like the grenade, if you will, vacuum, and it's on suction. Now, if that opens up, then it can happen, because I remember once a patient slept on it and now,
Oh.
and it opened up because they were twisting and turning. It can happen, it is not 100% foolproof. Also, the drain itself can go in and out, and that can seed the bacteria that's on the outside of the tube and whatnot. I will tell you, I myself presented at an international conference in 23, my 1,000 explants, and I said you do not have to have drains if the surgery is done correctly.
Okay.
Because all the badness is removed, the meticulous, tedious dissection to remove all of the capsular tissue, and now the need for the drain is not there, because anytime silicone spills into the chest or the capsule is left behind or cauterized, that burden continues to weep, and now the drains become mandatory. And so this is where the surgery absolutely can be done, to the point where I've not placed drains in any of my patients in well over 5.5 years. The last time I did, I made a cut, and now the free-floating silicone was pouring out because of the trauma, and it was an extra capsular spread of the silicone, and now the decision was already made because there was no way around it, because she had extra capsular extravasation of the silicone. Now, let me ask you this. You saw yourself, you're 68, you had implants, and above the muscle, did you need a lift?
I am so surprised. I am so surprised that, what I saw, no, I did not need a lift.
And this is just the start. And I will tell you, credit goes to your plastic surgeon. If you ask me, having removed a lot of implants now, credit goes to your plastic surgeon who placed the implants in the right place, in the right, and it was technically done very proficiently. And because of that, you can see the results do not mandate or require a lift. Now, your implants were reasonable volume. If they were the 600-800 cc's, absolutely you would be a candidate for a lift, because there's so much of the tissue that would have expanded. But one would expect someone 68 that would need a lift, and absolutely not. I have a 78-year-old patient that I saw a couple of weeks ago. Excellent surgeon, did not need the drains. Another patient, 70, did not need the drains or the lift. Another 89-year-old, the oldest patient, she did not need a lift or drains. And so the point here is no unnecessary surgery. And I would love to put drains, but the drains are not required when the surgery is done. The burden lies on all those surgeons who are putting in drains, because the drains are not required. None of my patients go on Facebook and say the surgeon was great, but I needed drains. No, none of them, because the only times the drains become an issue is when the patient says that I do not want to wear the pressure garments, the bra and the binder.
That, if I may interject.
Yes, and no, please.
Something that was really interesting to me, because like I say, I've had drains before, but I've never had this just explant until now. And so the binder, the compression bra and the binder, I noticed that the surgery I had was a lot. It was pretty, I don't know if you use the word invasive, but yes, you get black and blue.
Intense.
Intense, yes.
Remember, this is a surgery that if you go to 100 surgeons and don't even mention the word end block or total, they will never do it.
Probably, I would think that's probably the good word then, intense. And so, yes, you know, I got swelled up here was the first thing I noticed, and bruised. You can kind of still see it. But what I thought was really interesting was when I opened up the bra, it looked like a tan line. And I thought, you mean this, even this little amount of compression is stopping the bruising? It instantly, from that, it made sense to me that I knew I was all gonna be okay in here. I might be hurting, but it was not a need for drains because it was compressed.
Right, now this is plastic surgery 101. You get thigh lift, arm lift, tummy tuck, gynecomastia surgery, any surgery, certainly an explant, you have to have compression. Look at the marina garment industry, right? They're all based off compression, immediate after, long-term after, and this is plastic surgery 101. So compression is required. So if you hear, now if you look at those pictures and those videos, after a tummy tuck, you cannot do sit-ups, you cannot move around, you cannot go to the gym. Likewise, your surgeon, if he or she tells you that you can go to the gym 2 weeks after, 3 weeks after, 100%, you did not do the right surgery, because if it is that invasive, you cannot go about moving your arms, because you're only going to disturb what is a very large area, in your case above the muscle, and you do not want to move the breast tissue with respect to the pectoralis, because you want to let it settle, because it's an extensive area of dissection. Now, let me ask you this. I have to say you were very well prepared. You had done like a PhD in how I do it, why I do it. You had done and read up and seen almost all my videos in the last couple of months. So it kind of made you a better patient. And so this is what many patients ask me, what is it that you can do in order to make the whole experience better, is to be well read on how I do it. Now what's interesting is you talk about 10 other surgeons, each one of us will do it differently, because they have their own thought process, they're doing different cuts, they're more fixated on a lift, they're more fixated on a fat grafting, they're more fixated on God knows what else. But this is where you need to do the homework and say, what is the goal of the surgery? Now, in your case, you had what was a ruptured left breast implant.
Correct.
The word en bloc had to be absolutely very much and very appropriately done and used. And the surgery was exactly what surgery was needed on the left side, so that all the badness was contained. And I want each and every one of you to please go and see the pre-op interview, the intra-op findings, and certainly kind of put the whole story together, because I want to say this is not the ending, but this is kind of the after post-op results, so you can see the intensity of the surgery. And your surgery was not easy at all, because it was hard, it was painful, a capsular contracture grade 4 that you had on the left side since 1999, and the goal was to very meticulously dissect such that only the bad tissue was removed. And you will see this on that Facebook Live from the operating room, done on Thursday. What day was Thursday?
September 4th.
September 4th, yes, September 4th. So I want you to please go see it. I did one Facebook Live that day, so you can see firsthand exactly what was done. And the goal was to leave behind all good, healthy, viable tissue. And you can certainly see and notice how well you have done post-op. Now, what have you noticed post-op? Anything different? Now, I know it's too early, but it is never too early to ask and see where and how you have improved.
After reading all of the, I can run faster, jump higher, my eyes are super white, my teeth straightened out by themselves, all these kinds of, I'm being silly, but there were so many things that people said before and after, like immediately after surgery. And so I was really interested to see, okay, let's just see. The one thing for sure that I noticed, and this wasn't until a couple of days, because I wanted to be really cautious with this, was I have had severe lumbar and really like lumbar sciatica, like so severe, especially in the last several months, that I have these salon paws patches that I just patch myself up with all over my lower back, and I haven't felt that. Do I still get a twinge of the sciatica? Like 2 or 3 times since surgery, I'll feel this little sciatica, but it's not from pain medication, and I'm pretty sure the Exparel stayed
It's local.
local.
Yeah.
So this is the only thing.
How long was
that's
that
huge.
How long was that hurting you?
I've had lumbar and sciatica problems for probably about, I'm gonna say around 8 or 9 years
Wow,
now.
okay, so.
It flared up
yeah.
a lot.
So this is a nice, good start. What we're gonna do is I'm gonna see you again on September 20th in California.
Yeah.
So we're gonna do a follow-up Facebook Live there, and then
Yes.
we're gonna follow up on this. Then we're gonna follow up on another one, let's say 6 months or 8 months, 9 months out, because if you have had these symptoms for 9 years and now you're seeing improvement, we will see where and how it's gonna be 3 weeks out.
Mhm.
We're gonna see where and how it's gonna be 6 months out, because you're not the first person who said this, and so this is where the heal is real. And remember, the hallmark feature of breast implant illness are the rheumatological joint problems.
Mhm.
So those patients who question, should I even have to do the end block? In your case, if the end block was not done, that implant, the slime, if you will, would rupture and spill into the periphery. And no matter how much you wash it out, you would basically spread it. And I remember you asked me this question very logically that one time that we were pre-op. What happens if you wash out the silica? You essentially distribute it. If you imagine you're playing with slime, and now it gets into a small focal area on the chest. This is a ruptured silicone when someone is not prepared for the end block. And now when you wash it, what it is gonna do is it's gonna spread it out even more. And so now that burden is gonna spread even more, and you're gonna essentially not wash it out. Or the drains, for example, someone said, all the toxins are gonna wash out. No, they're gonna embed within the fatty tissue, and it is not gonna be removed. What's interesting is the patient right before you, right now, 10 minutes ago, 15 minutes ago, is a patient that came from Utah. She had her explant already done in 22. Her augmentation was done 2014. She then got so sick and she got her explant in 2022. Her surgeon did not remove the capsules, and now the goal tomorrow is to go in and remove the residual capsules, because she herself has gone through the whole series of tests and whatnot else, and ultimately the answers have yielded nothing. And so she's essentially cornered into getting an exploration surgery. Her surgeon did not believe in breast implant illness, did not remove the capsules, and the task tomorrow is to remove the capsules, and then we will see in what capacity and how she's gonna bounce back. Like the many other patients who have come to me where the surgeon, the first one, did not do the right job thoroughly. Because the goal is to do it right, do it complete, do it thoroughly, do it meticulously, wholeheartedly, honestly, so that when we look back at it, no more could be removed. And in your case, no more could have been removed, but all what was good was left behind, so you have that precious volume on your chest. And this is where that care and precision and that minimal but good, effective, practical dissection is done. Another patient, so I talked to a patient from Bulgaria this past couple days ago, and same story, residual capsule. And I posted a video of one of my patients where she had a residual capsule and I was dissecting it off, and one of the patients who was listening and saw the video said, well, you're operating on a moving target, which is the patient's breathing. And I said, you bet. So even if you're breathing, be it on twilight deep sedation like it was your case, or on a patient who is on a ventilator and the machine is breathing, the chest is always moving up and down. So whether you're breathing by machine or better like you were with yourself, you will have to operate on, quote, what is a moving target. And this is certainly what makes it a little bit more challenging, because now you have a patient's chest, whenever anyone takes a nice deep breath, the chest moves up and out. And when you exhale, it goes down, and you see this in the videos as well.
Yes, I did.
Yeah, now the hardest part of the surgery is to dissect on top of the rib underneath the muscle. But in your case, the left side, because of the rupture and extreme inflammation and the severe tight contracture, added absolutely to the whole challenge of the surgery. So your case was harder, even though it was above the muscle, than the case that I did to follow, which was below the muscle, and relatively easier, even though it was below the muscle, which was supposed to be harder, if that makes sense.
It does.
So any time of the day, I will take someone post-menopause, 50s, 60s, late 50s, anyone with above the muscle, anyone with not ruptured small implant and non-textured. In your case, yes, you were 68, so that was easier dissection than the 37-year-old that came to me from Chicago who I just saw off. You were supposed to be easier because you were above, but believe it or not, because you were above and how tight you were, that was hard. And it was not an easy case as you saw in the pictures and the videos.
I did. And also going back to what you were saying about the capsule, because I got some of my response from LabCorp
Yes.
on the, is it strepto?
So
no.
that was the Staphylococcus
Yes,
aureus. That was one of the bacteria that came back already positive. This was on the left side. And so you are already on the antibiotic. You have no signs, symptoms of any
Right.
infection. And I will tell you, to date, I have had only two questionable patients who have had infection. And this is why I give the antibiotics to all my patients, so that biofilm or whatever, remember, it's completely removed, that the chances of getting an infection essentially, I would say non-existent.
Right, and so my point with that was, so many different women have explant so many different ways because of so many different techniques and surgeons, and it always has, once I learned about en bloc, which was actually many years ago, and I knew that's what I wanted. Take the whole thing. Don't just take the whole thing. So people that leave this capsule behind, and I know it's a hot point with some people and some doctors, they'll say, oh, it's really thin, or it's only X amount of months. In 1 year, this went from being a brand new implant to severely encapsulated, like rock hard in 1 year. So leaving that capsule behind, that's where so many problems, it seems logically from all the things I've read and videos, leaving it behind is not such a great idea.
Right, so this is the take-home message. The capsule in itself, this whole surgery is about the capsule. Anyone can remove implants. So in your case, had the capsule not been entirely removed, the silicone would have spilled into the chest. You would probably be having drains and not feeling better because it would have spilled, the silicone would have been spilled. And we know that silicone is not like a relatively benign. If you take the silicone and put it on your thigh, you can imagine the caustic effect and whatnot else of the silicone. This whole surgery is about the capsule because we know from the many pathology specimens of the capsule that were sent, it showed silica, non-polarizable material, giant cell reaction, chronic inflammation, silica particles within. And so if you leave that behind, that in itself will continue to be a trigger, and you would not improve completely definitively. This is where now, and this is what I said, I believe in the Facebook Live, 20 years from now, I cannot imagine anyone else doing the surgery any differently, because no lift, no drains, twilight deep sedation, implants return to you, cultures for aerobic, anaerobic, and fungal, the capsule sent to pathology, and you got the same surgery that I offered the 31-year-old, the 22-year-old. And this is where consistently from one patient to the next, that the entire capsule, inflamed tissue, and anything abnormal, even remotely suspicious, was removed, because remember, you had the history of that rupture on the right and possibly on the left. And so now as you head back home, you will have the peace of mind that all the bad news were removed and all of it was tested. This whole surgery is about the surgeon's personality, if you ask me, where the surgeon wholeheartedly believes that the capsule must be removed. Because if that is not done, you do not want to second guess the process and say, well, I wish I removed it. I wish I had, because I'm not 100% better. You have, by looking at those videos, that peace of mind. Yes, he did whatever he said he would. Be it today, be it last year, be it 5 years ago, and 5 years from now. And that is the whole gist and essence of the surgery. And that is what every surgeon, now any surgeon who wants to do an explant, you will see every surgeon has a personality. I saw one of my patients alerted me to another surgeon and said, look at these pictures, they're all perfect. I said, I will tell you, all these 10 perfect pictures are there to, sorry to be used the word, deceive you into thinking you're going to be the 11th. If someone has a ruptured implant on one and a radiated chest on the other, that person's not going to end up on that. And so this is when I made my website. They said, we can get you model patients, we can get you other patients. I said, absolutely not. You're only going to find my patients. I don't go around saying, oh, these are my, out of, right now I probably have 300, 500,000 pictures. I'm not gonna go with my team on a Saturday and say, I want this one, I want this one, I want this one, and I'm gonna put the top 50. No. Every case is different, every site is different. One patient had 4 surgeries last week. Her results are gonna be different on that one side where they only touched her right side once, for example. She had capsular contracture on one side. And the point I'm trying to make here is, you have to understand. Another thing that was important was I saw a surgeon doing a BBL. I will tell you which is the Brazilian butt lift, and this is, if you ask me, from a professional scientific perspective, this is the most dangerous surgery that's done in the United States and probably the world, where you have fat emboli that can go. It is very rare, but it does happen, and you can do your research. This is a surgery, if you ask me, should be banned. Number 2, from a ethical, professional perspective, ethical and a human perspective, this is making a mockery out of the human body. Someone who's 30, 27, who wants to get this surgery, if you ask me, the surgeon should not offer it because the patient wants it. Because one of my acquaintance plastic surgeons, he said, I'm offering it because the patient, I said, you should not do something because someone else wants it. You should not do it to begin with. And the bottom line here is, yeah, I find that is a surgery where no surgeon should be doing it because of the reasons as mentioned above. And the point I'm trying to make here is, you want to talk to your surgeon, you want to have the confidence, you have to have that excitement that you know that you're going to get the surgery that you signed up for, which is complete total capsule removal plus the implant. And like you very well mentioned, it's all about the capsule and the way to preserve it such that none of the silicone spills into the chest.
It is, because once I saw what really can go on with the capsules, no matter what kind of implant, no matter how long, no matter the patient's age, you can't unsee some things. And that's something that I could not unsee. It's like, no, that whole unit needs to go for my peace of mind, because this is, for me, this is a one and done. This is like, I'm done with that, and I wanted it all gone. And that very night I was thinking how thankful I was that it's done. It's all out, and I'll get the pictures, at post-op. So there's a huge relief in that. There really is. And I know it's just a matter of time for people to learn a little bit more that it's, of course, the first thing a person usually considers is finances, money, right? And then you go but you keep doing your homework, but learning about those capsules and all the different things that they can contain and hold, even if you're not having any symptoms, even if it's still early in the game, if you get them removed, good, just get the capsules out and then go from there.
See, another point is very rare that you can get lymphoma, the BIA, breast implant associated anaplastic large cell lymphoma, the BIA LCL, or the BIA breast implant associated squamous cell cancer, and others. Very rare. And you want to have the peace of mind that, God forbid, that implants ruptured. Now, I took care of a patient, she had implant silicone from 2021, just 4 years old, and she was ruptured on the right side. Total surprise. If you're that patient, you're gonna have had it removed in the end, well, complete total capsulectomy, so you don't have to worry about the silicone spilling into the chest. Number 2, that 3 patients, now that I've seen 4 patients with CD30 positive, you're removing the whole capsule so they don't have to come back and remove the residual capsule because it was done right to begin with.
Right.
Number 3, the 3 patients with breast cancer. Now, they had breast cancer to begin with, but when I removed these reconstructed patients, their capsule, the mass, whatever, I removed, 3 of them had breast cancer in them. And so they already got their surgery to begin with. The many patients that have had fluid around, that none of it spilled into the chest, had I not done a total capsulectomy in the en bloc fashion or 100%, they would have had that spillage, and that would be quote unquote a catastrophe to manage. So it's all about that peace of mind. So post-op, when you got done with the surgery and you put your head on the pillow, that peace of mind, that tranquility, that you got whatever you signed up for.
And it's real.
Not like that patient from Bulgaria that I talked to a couple of days ago. She got her explant done and the surgeon left the capsule behind. A year ago in October of 2024, she sought another surgeon out in Spain, and her job was to just remove the capsule. And lo and behold, she was not successful. And she said her symptoms are much worse, because what she did was she cauterized the capsule, and now the symptom spread was more, supposedly, and this is what the patient is saying. This is very similar to the German patient I took care of a year ago. She got an explant and did not improve, and the surgeon was supposed to remove the capsule. Then she went to another surgeon who was supposed to remove the residual capsule, and to no success. Now, as I went in, I was going to be the 3rd surgeon post the explant, and I was supposed to remove what the other 2 surgeons could not have done. And lo and behold, I found, and you will see the Facebook Live I did. So this whole surgery is about, number one, the surgeon in his or her mind completely, definitively, honestly, sincerely believing that the capsule must go, the point you mentioned. And number 2, the surgeon must physically be able to carry out the task of removal, because even when the surgeon wants to, sometimes when the going gets tough, they physically are not able to, because it is a very tedious, meticulous, and it is not for everyone.
And how often I've read that in various different Facebook groups about people saying, well, you know, my surgeon says it doesn't need to go, or I'll remove it, whatever I can. You know, I'll remove as much as I can. And I think, well, there's a little bit of a problem there, because that in itself says your capsule's gonna be open. Anybody in the body, by the way, anybody who's watched any of your videos, especially some of those women that when you do the cutting open of the capsule in the surgical room, and it's these fluids come out of some of them. The one like peanut butter, that was just like, it's beyond me how the body does that, but I wouldn't want any part of any of that in my body to be left behind, or how do you even clean that out?
Now, I will tell you, are one of my, and I will tell you, every patient that comes to me and travels, they have done their homework, they have researched, they have networked, they have talked to my previous patients, they have seen my videos, if not memorized them, literally. Now, how many, and you don't have to mention any names, you know, how many surgeons have you talked to, or have you heard, or have you researched?
Just most recently, my first thing was I live in Las Vegas, so I looked at 2 in Las Vegas. I looked at 3 in Southern California, because how nice that would be to have, you know,
right there,
stay right there by the beach. And I watched their videos, so there's 5. I had already known about one in Ohio. I already knew her game was top notch. So there's those. I actually called to make a consultation with the one in Las Vegas, but I didn't like the idea of drains. I didn't like the idea that there were no photos. I don't know if any other, I haven't seen it yet, and again, I'm gonna say, if anybody knows of any other explant surgeons who will offer so many photographs and evidence and show
videos of the chest wall, yeah.
I mean, I don't see anybody else doing that, and there's a huge amount of I, importance on that, because I know it's done. I know my chest. I know that that was me.
Mhm.
You know, I, I, I can't just say how important that was. It was really important,
So the single most important thing, and I'm gonna echo what you just said, you have to have the video of the chest wall showing complete definitive removal. And not that you have to grab it out of the surgeon should be giving and sharing it with you. We as plastic surgeons, if you ever wanna tell a plastic surgeon who's entering the hospital, you just look at his bag and it has to be a camera bag.
Mm.
So we take care of dog bites, moles, melanoma, skin cancer, before, after. We are instructed, taught to take pictures before, during, and after. There is no HIPAA violation in taking your pictures and giving them back to you and telling you that this is what was done. If anything, this should be part of the contract. Consent.
Oh, yeah.
You must provide pictures, videos, high definition of the chest wall showing complete removal of the capsule, and with light, high definition all the way inside into the upper chest with the instrument, the deaver, so that we can see what was removed, what was left behind, and that the integrity of the surgery was indeed as was discussed. And number two, cutting open of the capsule and implant. This should be 101. Now, if you were to get your gallbladder out, who cares? It's out, it's done, right? This surgery is where you have, number one, if you group together 1,000 plastic surgeons, all 1,000 of them are gonna be in disagreement. Majority of them are gonna say who removed the capsule, why? It's too invasive, it's too risky, it's too expensive, it's not required. 95, 97, 99% of them. And of those others, they might be just wanting to be politically correct and say, hey, I don't wanna lose you as a patient and I'll offer you whatever you are. They should not be augmenting, they should be openly discussing on their Facebook, on their Instagram, on their TikTok. Now, the TikTok and Instagram are relatively and Facebook too, are very cautious about showing this graphic content. But YouTube, you can put like a nice big cover and say not for kids above 18, and you give permission. And I want each and every single patient to demand, require, ask. Now, the reason is why? So that we don't reproduce what's gonna happen to this very last patient who came to me. This nice patient's husband is a doctor. And you can imagine they are very, I use the word seasoned, they know the medical community, they know people, they know the lingo, they know everything. And she got compromised, and for the last 2 years, she's been hurting. And she says, I have a hard time even getting out of bed. The point I'm trying to make here is we do not want a patient to end up like that. We want the patient to be like you. And I will tell you, for me, it's all about education. I can only do so many of these in a year, like I was talking about earlier. The bottom line is do it once, do it right, do it thoroughly. And like I was telling one of the ASPS presidents, do it such that when you look back at it, you say you could not have done a better job, and the patients know and they give informed consent of what they signed up for, just like you did.
Right, right. I concur,
Yes.
I concur. Yes.
All right. Well, safe travels. I will see
Thank
you
you.
in a few weeks in California.
Yes.
And so please, by all means, for those who are not aware, we're opening up another location in Los Angeles, and we hope to have clinic there regularly, every 6 weeks or thereafter, depending on the patient load. It doesn't take much now to travel. It's like getting on a Uber and 4 hours, 4.5 hours later, getting to your destination. This is where you want to learn more about me. Go to the YouTube page, go to the Facebook page, Instagram, TikTok. YouTube by far, Mar has done a wonderful job putting a lot of information on YouTube and Facebook. Educate yourself on how I do it, why I do it in the manner that I do, and ask questions, talk to the surgeon's previous patients so that you educate, you're completely happy, transparent, and that you have a true bond and excitement as you proceed with the surgery, so that when you look back at it, you are as you travel back content and happy and all smiles, and that you're not second guessing the whole process.
Yeah, and I wanna add one more thing on your Facebook group. I'm in like 6 breast implant illness groups on Facebook. But in your group, I've already met 3 ladies that, you know, two of them I've spoken to on the phone, and one of them lives in Nevada, in my state, and we've been able to share so much, and I can text them or message them already with questions, or because we've all had you and know, you know, what your program is, so to speak. It's really been great. And I noticed there's a lot of women in the group that do ask questions about your technique. And I did want to ask you again, and I think you covered it, the importance of the binder.
Mhm.
Like, really, the importance of the binder is mainly about the keeping seroma away, or keeping the body more steady to heal and
Right, right.
fuse.
So let me go ahead and expand on that.
Sorry.
No, this is a very good, and I
Okay.
will tell you, 3 months down the road, if you want to, and remember, I have no disclosure, I have no financial commitment with you. The only
Right.
intent and purpose here is to help the next patient and the surgeon and the significant other who's listening. If someone gets a tummy tuck, they dissect all the way up into the subxiphoid area, and it's a big area. And when they basically put everything together nice and tight, 100% of the time they wear these compression garments. Why? Because the patient's gonna twist and turn in bed, they're gonna walk to the bathroom, they're gonna sit in a chair, they're gonna lie down, there's gonna be movement. So we don't want movement up and down with respect to the abdominal wall. Likewise, on the chest, which is relatively very intense and invasive, just like you very well mentioned, you have the area where now so if someone gets a tummy tuck, that's like a natural, healthy, good area. If you look at the chest breast area, this area is angry, irritated, inflamed. You can see the dilated veins. So it's not a healthy area like the tummy tuck. Now, the area where the implant was sitting, the ruptured implant on the left, the angry, inflamed tissue, the weepy, whatnot else, because remember, it's irritated. Now, the compression, just like with the tummy tuck, becomes mandatory, so that you're gonna hold the tissue so that when you're reaching for the glass of water, the same day or the next day, or you're making yourself a sandwich, or you're on your phone, you're not gonna cause the shear forces. So when you wear the bra holds you like this with a nice big elastic band, and then the binder kind of gives you a push-up, so that when on your car ride, there's no movement up and down. And that is the whole intended purpose, 101.
Okay.
Any surgeon who does not put a garment, they're doing a plastic surgery disservice, because just like with the thigh lift, tummy tuck, gynecomastia, arm lift, explantation, you have that void where the implant was sitting, that needs to be held back up so that the patients do not get a seroma, and they basically heal optimally, and that basically heals in the manner as we want it to.
Right, thank you,
You're welcome.
thank you.
And I know you asked me the question about the pseudo-lift. So that is, I remember all the questions, because you know what, you're like the spokesperson for the many patients, because you've done a lot of talking. I will go ahead and have a video that will show exactly what that means, and I will do kind of like a tutorial, if you will, where it's a removal of the skin at the bottom, especially with the implant bottoms downward and outward, bottoms out. I remove that excess skin such that when I put the internal sutures, that helps lift the breast tissue up, and that is truly a recoil. As in your case, you see how much of the tissue that I removed, and that truly helps over time, just like over the next year and a half, when everything settles. This is how long it takes for any tummy tuck to settle, someone who has given birth, the tissues to recoil, the uterus to normalize. Now the first 3-6 months are key, but you will see 9 months later, they're still in the healing phase. And you will see between the recoil of the skin and the breast tissue, between the fluffing effect, between the implant sitting on the chest causing a contour deficit of the rib, between the inflammation that's causing everything to weep. Just like someone gets a bad mosquito bite and now the whole face, eyes shut and weeping down. With that inflammation subsides on the chest, between the 5, 10, 15% muscle mass you're gonna add to your chest, between the swelling coming down, you're gonna see aesthetically, you're gonna be even better than where you are today. And healthier physiologically, you're gonna be able to throw a ball much further out than, let's say, last week. So it's only improvement for the better. And no unnecessary cutting. I will say I love to operate. I wish I was operating right now. I wish I was operating on the weekend. And I will tell you, no unnecessary operations, no unnecessary cutting, no unnecessary lifts, no unnecessary drains, because you did not need the drains. Like the 1,000 patients before you did not need the drains. And it's been well over 1,000 patients who have not had drains, and the consecutive 1,000 patients before you. The point I'm trying to make here is, it's a very systematic, thoughtful, honest, respectful surgery. If you ask me, it's all about respect, this whole process. Respect for you, how I handle the instruments, with respect to how I use the bovie to dissect, how I respect your symptoms, how I respect the ruptured implant, how I remove the capsule, leaving behind nothing, how I respectfully see what your concerns are, how you want to look afterwards. And as you leave, it's all about giving 100% from the heart, not just like doing another surgery because it can be done, but doing it in a very systematic, thoughtful way. A surgery that, if you ask me, having talked to a lot of plastic surgeons, not everyone wants to do. Yes, it is hard.
Clearly.
Yeah, for the right reasons, but it must be done. Just like the Whipple procedure around the pancreas. I don't wanna do that. I can, and I'll tell you I would be good at it, but I choose not to, right? I missed the hand, like one of the patients asked, you were a hand surgeon before. No, all plastic surgeons are hand surgeons. And if you ask me, hand surgery is more involved than explant. Explant is hard in its special way, just like your left side and certainly the right side was. But all plastic surgeons are hand surgeons. A fourth of our exam is hand surgery, by the way. Yep, so putting together a amputated finger, reconstructing the thumb, for example, congenital problems that we have. And again, you have to be trained in the Children's Hospital as a subspecialist in pediatric plastic surgery. So we have our own areas of expertise. Like, I will never do a nose in my life because that's not my cup of tea. The bottom line here is the surgery is meticulous and it needs to be done with respect to the whole process. I'll let you finish.
No, I'm done, I'm good. I just, do your homework if you're looking to have explant. Really do your homework. I think I said this before. The groups are wonderful, of course. But you have to use your own brain and figure out things. And the best way, honestly, I found is watching videos of different surgeons. Like, go, if you find a surgeon you want, watch their videos. Listen to what they talk about during their surgery. It's kind of amazing.
That is very important. So I will tell you, I wish, and remember, this is where, I like, I don't want to say something that might be taken differently. Let's say you like 10 different types of art, right? And this is a good analogy. You like this type of art, spray art, another one oil painting, another one with the water. You have 100 different artists. You don't want to just look at the picture, you want to see how they're painting it, because if you ask me, that's a certain joy in watching that, yes. Right? You want to see, now I will tell you, I wish through AI, tell ChatGPT, find all the videos for every surgeon, and surgeon A in California, surgeon B in Texas, surgeon C in New York, surgeon D in Michigan, surgeon F in Florida. Show their videos, how they do it, why they do it, and explain how they do it, and what are the results, and what are their patients saying about it. So now this is pure informed consent.
Exactly.
So now on your website or the next patient's website, they objectively, without any financial commitments to anyone, to any surgeon, and only a financial commitment to who? God. right?
Amen.
Yeah,
Mhm.
that you have no other vested interest to support a surgeon because he donated, or another group that you like because they happen to be in your home state and they invited you to a Lions game. None of that. That you objectively show high definition pictures, not once, twice, but repeatedly from one patient to another, so that the patients can see how the surgery was done, how the painting was brought about, and what is the technique, where are the cuts, just like I have shown on my YouTube. So now the patients are not confused. They know what they're signing up. On the consent form, end block or 100% total capsulectomy must provide high definition pictures and videos of the chest wall. If that's not what you're getting on the consent and repeatedly, then there is a problem. There needs to be complete transparency from the beginning to the end, so the patients know what they signed up for. And that is, if you ask me, the ultimate way to do the check and balance on your surgeon, including myself.
Yeah, including you. God bless you.
Thank you very much, and
Thank
God bless everyone, yeah.
Yeah,
All right,
thank you.
okay, all right. Take care till next time,
Okay.
September 20th.
Yes, I see you then.
Yeah.